Hello, Assalamu alaikum wa rahmatullahi wa barakatuh. Dear students, we have discussed already the metabolic process and metabolic process. Today we are going to discuss the respiratory acidosis and respiratory. The definition of the respiratory acidosis is the hydrogen ion is greater than 40 millimole or 40 nanomole per liter, and the PCO2 is greater than 5.3 kilopascal. Bicarbonates are greater than 20 millimole. In acute cases, the bicarbonate rise in millimole per liter is equal to 0.75 into PCO2 rise in kilopascal. In chronic bicarbonate as per respiratory acidosis, bicarbonate rise in millimole is equivalent to per liter is equal to 2.62 into PCO2 rise in kilopascal. The respiratory acidosis is due to the accumulation of carbon dioxide in the blood, and this results in the production of carbonic acid and hydrogen ions, and the causes of which results in increase in hydrogen ions and hydrogen ions. And in the result in rise in PCO with compensatory increase in carbonate concentration, particularly in the disorders of long duration, and the kidney has fully developed its capacity for increased acidification. The acid-base disturbance can arise from region anywhere along the neuromuscular pathways from the brain to the respiratory muscles that result in impaired. So the main aspect is impaired ventilation. It can also arise during interstitial lung disease. There is a significant mismatch of ventilation and oxygen. The cause of acid-base disturbance can arise from lesions anywhere along the neuromuscular from the brain to the respiratory that result in impaired ventilation. Can also arise during intrinsic life. There is significant and of ventilation and oxygen. The most common causes of respiratory acidosis are type 2 respiratory failure types. That is, in those conditions in which there is anemia and there is increased PCO2 or hypercarbia. The acute type 2 respiratory failure is occurs in cases of or acute respiratory acidosis occurs in acute CRS, acute exacerbation of CO, upper respiratory tract infection, acute neuropathies and practices, acute neuropathy and narcotic drug, primary alveolar hypoventilation, plain chest injury, chronic type of respiratory failure are COPD, sleep apnea, sleep apnea, hyposcoliosis, myopathy and muscular dystrophy, ankylosing spondylitis. These are the causes of chronic obstructive. Once again, the respiratory type 2 respiratory acidosis occurs when there is accumulation of CO2 due to type 2 respiratory. And because of this results in a rise in PCO2 with a compensatory increase in plasma bicarbonate concentration, particularly when the disorder is of long duration. The kidney has full developed its capacity for increased acidification. The acid-base disturbance can arise from region anywhere along the lymph pathway, from brain to the respiratory muscle. That is impaired. It can also arise during intrinsic lung disease if there is a this message of ventilation and acute type 2 respiratory failure syndrome are acute respiratory acidosis, acute exacerbation of COPD, upper respiratory restriction, acute neuropathy and paralysis, narcotic drugs, primary alveolar hyperventilation, pleural chest injury, chronic type 2 respiratory failure, chronic causes of respiratory acidosis are COPD, sleep apnea syndrome, kyphoscoliosis, myopathy and muscular dystrophies, ankylosing spondylitis. Symptoms of respiratory acidosis depends on underlying respiratory disorders such as paralysis, chest involvement, but the CO2 accumulation may itself lead to tremors and further depress the respiratory tract. Symptoms of respiratory acidosis are headache, anxiety, blurred vision, restlessness, confusion. Without treatment, other symptoms are sleepiness or fatigue, lethargy, delirium or confusion, shortness of breath. Common symptoms of respiratory acidosis, acute respiratory acidosis are headache, anxiety, blurred vision, restlessness, confusion. Without treatment, other symptoms such as sleepiness, fatigue, lethargy, delirium, confusion, shortness of breath, coma, chronic respiratory acidosis symptoms are memory loss, sleep disturbance, personality changes, coma and death. The management of involves correction of causative factors where possible, but ultimately ventilatory support may be necessary. This was about the respiratory acidosis. In case of respiratory alkalosis, there is respiratory alkalosis develops when there is a period of sustained ventilation resulting in reduction in PCO2 and increase in pH, reduction in PCO2, increase in pH, reduction in PCO2 and increase in plasma pH. If the condition is sustained, renal compensation occurs such as tubular acidosis and secretion is and the tubular acid secretion is reduced and the plasma bicarbonate levels fall. Respiratory alkalosis occurs. Respiratory alkalosis when the pH of the hydrogen ions of blood falls below 40 nanomole, pH is greater than 7.4, PCO2 is less than 5.30, and bicarbonate level is less than 24 milliliter. Acute bicarbonate fall in is equivalent to 1.50 into PCO2 fall in kilopascal. Chronic bicarbonates fall in millimole per liter is equivalent to 3.75 into PCO2 fall in kilopascal. That means in the respiratory alkalosis, carbon dioxide level falls and bicarbonate levels compensatory as a result compensatory response. The causes of respiratory alkalosis are respiratory central stimulation, such as CNS disorders, tumors, infection, and hepatic failure, sepsis, pregnancy, anxiety, panic disorder, pain, drugs as pain, progesterone, quercetin, catecholamines, psychotropics. These drugs are stimulant of respiratory system and can cause respiratory illnesses. B group is hypoxia as a result of pneumonia, pulmonary edema, pulmonary embolism, pneumothorax aspirate. This leads to hypoxia and respiratory center stimulation. Cardiopulmonary diseases, pneumonia, pulmonary edema, emphysema, pulmonary fibrosis, pneumothorax, pleural chest, pulmonary embolism, high altitude, chronic heart failure, mitral valve disease, mechanical hyperventilation. Respiratory psychosis is usually of short duration, occurring in anxiety states as a result of poor vigorous assisted ventilation. It can be prolonged in state. Pulmonary embolism, chronic lung disease, and injection of certain drugs such as salicylates or drug that drug stimulates the respiratory center in the brain. Clinical features are those of underlying cause and agitation associated with perioral, perioral and digital dimming matter as alkalosis promotes the binding of calcium to immune, resulting in reduction in ionized calcium concentration. In severe cases, Rosier's sign and touristic signs. Rosier's sign is when you like cough and raise the BP above the diastolic BP and keep it there for few 1 minute. The carpal spasm of the hand. This is called sign. Joystick sign is the just or clicking on the facial nerve cause facial twitching, and tetany and seizure may develop in the late stage. Sign and symptoms of respiratory tuberculosis include neurological, lightheadedness, numbness and tingling, confusion, inability to concentrate, blurred vision, cardiovascular system shows cardiac dysarrhythmias, palpitation, and diabetes. Miscellaneous are featured are dry mouth, tetanic spasm of the arms and legs. The management involves correction of identifiable causes, reduction of anxiety, and a period of rebreathing into a closed bag to allow CO2 levels to rise. These are the two mechanisms of respiration which cause acid-base stages. Let's discuss once again. Respiratory acidosis, in which the hydrogen ion of blood are greater than 40 nanomole per pH, greater than 7, less than 7.40, and PCO2 is greater than 5.33 kilopascal. Bicarbonates are greater than 24 millimole because carbon dioxide forms carbonic acid and hydrogen carbonates are formed. In acute respiratory acidosis and chronic respiratory acidosis, there is in both conditions there is rise in the bicarbonates. The ratio of rise of bicarbonates is 0.75 into PCO2 rise in kilopascal, and chronic bicarbonate rise in millimole per liter is equivalent to 2.62 into PCO2 rise in kilopascal. So in respiratory alkalosis, the hydrogen ions of the blood are less than 40 nanomole per liter. PCO2 is less than 5.33 kilopascal. Bicarbonates are less than 24 millimole. And in case of acute and chronic conditions, the bicarbonate levels fall. The fall of bicarbonates in acute respiratory alkalosis is equivalent to 1.50 into PCO2 fall in kilopascal. In chronic respiratory alkalosis, the bicarbonate fall in millimole is equivalent to 3.75 into PCO2 fall in kilopascal. Now, the causes of respiratory acidosis are acute respiratory acidosis are those of acute respiratory type 2 respiratory failure and of those chronic respiratory type 2 failure are the causes of chronic respiratory acidosis, alkalosis, chronic respiratory alkalosis. Acute type 2 respiratory failure or type acute respiratory alkalosis, acute respiratory acidosis, the acute severe asthma, acute exacerbation of COPD, acute exacerbation of COPD, acute respiratory acidosis results from acute type 2 respiratory failure. Causes are acute severe asthma, acute exacerbation of COPD, upper respiratory tract obstruction, acute neuropathies and paralysis, narcotic drugs, primary alveolar hyperventilation, pleural chest injury. Chronic respiratory acidosis are due to chronic type 2 respiratory failure. Causes are COPD, sleep apnea, kyphoscoliosis, myopathies, muscular dystrophies, ankylosing spondylitis. Symptoms of respiratory acidosis are acute respiratory acidosis is characterized by headache, anxiety, blurred vision, restlessness, confusion. Without treatment, other symptoms occur: sleepiness or fatigue, lethargy, delirium, confusion, shortness of breath, common. In chronic respiratory acidosis, the memory loss, sleep disturbances, and personality changes occur. The management of respiratory acidosis depends upon the treatment of the underlying cause and the ventilatory support. Respiratory acidosis occurs when there is accumulation of CO2 due to type 2 respiratory failure. This results in rise in the PCO2 when with a compensatory increase in plasma bicarbonate concentration, particularly when the disorder is of long duration and the kidney has fully developed its capacity for increased acid excretion. So now we go to that is called compensatory respiratory. That is called compensatory respiratory acidosis. In case of respiratory alkalosis, respiratory alkalosis develops when hyperventilation. लड़के इधर आना यार. ओ फिर मेरे बेटे लड़के इसको शेयर करो। नहीं अभी लेक्चर देना आ गया ठीक है। Sorry for interruption. Respiratory alkalosis is develops when there is a period of sustained hyperventilation resulting in a reduction of PCO2 and increase in pH of the plasma. If the condition is sustained, renal compensation occurs such that tubular acid secretion is reduced and plasma bicarbonate falls. Respiratory alkalosis is usually short duration. Causes of respiratory alkalosis are respiratory central stimulation, CNS disorders, hepatic failure, sepsis, pregnancy, anxiety, panic disorder, pain, drugs, aspirin, progesterone, theophylline, catecholamine, psychotropic drugs. D. Hypoxia. Any condition causing hypoxia, such as pneumonia, pulmonary edema, pulmonary embolism, pneumothorax, aspiration, or cardiorespiratory disease such as pneumonia, pulmonary edema, emphysema, pulmonary fibrosis, pneumothorax, flail chest, pulmonary embolism, high altitude, congestive heart failure, pulmonary hypertension, pulmonary stenosis, mitral valve disease, mechanical hyperventilation. If occurs, this can also cause respiratory alkalosis. Respiratory alkalosis is usually of short duration, occurring in anxiety states as a result of vigorous assisted ventilation. It can be prolonged in the context of pregnancy, pulmonary embolism, chronic liver disease, and ingestion of certain drugs such as salicylates that directly stimulate the respiratory center in the brain stem. Clinical features are those of underlying condition plus occurring in those of underlying conditions such as agitation. Neurological symptoms are agitation, numbness and tingling, perioral and digital, confusion, inability to concentrate, blurred vision, serious dysarrhythmias, palpitation, diaphoresis, miscellaneous, dry mouth, tetanic spasm of the arms and legs. Management involves correction of the identifiable causes, reduction of anxiety, and a period of rebreathing into closed bag to allow CO2 levels to rise. For we give a case to you, a patient with cough dyspnea of long duration. He is having COPD and his ABGs were carried out, which shows pH of 3.28 and his bicarbonates are 29 and his sodium and potassium are 9. What do you think this will be because this is a cause respiratory acidosis and you will treat the underlying cause that is COPD by bronchodilators and that will improve the oxygenation and reduce the CO2 level, and that will cause improved in turn production of carbonic acid and will improve the respiratory acidosis. During the last lecture, I missed one topic, that was the hypovolemic hyponatremia. That is syndrome of inappropriate ADH secretion. Syndrome of inappropriate ADH secretion. Syndrome of inappropriate ADH secretion is page number is the page number is 357 from the Davidson, and table number is 1411. The causes of syndrome of inappropriate antidiuretic hormone secretion are tumors, central nervous system disorders, stroke, trauma, infection, psychosis, porphyria, pulmonary disorders, pneumonia, tuberculosis, obstructive lung diseases, drugs, anticonvulsants, psychotropics, antidepressants, cytotoxic, oral hypoglycemic agents, opiates, idiopathy. These are the causes of syndrome of inappropriate antidiuretic hormone, large amount of antidiuretic hormone is the vasopressin or antidiuretic hormone promotes the water retention by the kidney in the absence of appropriate physiological stimulus. The clinical diagnosis required the patient to be the low plasma sodium concentration, euvolemic. In this condition, patient is euvolemic with no evidence of cardiac, renal, or hepatic disease potentially associated with hyponatremia. Other non-osmotic stimuli that causes release of vasopressin, pain, stress, nausea should also be excluded. So the features of hyponatremia, which are, that is, nausea, anorexia, nausea, vomiting, delirium, lethargy, seizures, coma occurs in these patients also. And diagnostic tools are low plasma sodium concentration, typically less than 130 millimolar per liter, low plasma osmolality, less than 2.27, less than 275 milliosmol per kg. Urine osmolality not minimally low, typically greater than 100 milliosmol per kg. Urine sodium concentration not minimally low, greater than 30 millimole per liter. These two are low, but not that minimally. Low normal plasma urea, creatinine, and uric acid. Low normal plasma urea, creatinine. Clinical euvolemia, absence of adrenal, thyroid, and pituitary and renal insufficiency. Absence of adrenal, thyroid, renal, and pituitary insufficiency. No recent use of diuretics. Exclusion of other causes of hyponatremia. appropriate clinical context required. So in these cases, the management includes the treat the underlying cause. The other is there is reduction fluid restriction. In this condition, there is fluid restriction and management involves fluid restriction, fluid restriction should be in the range of 600 to 1000 ml for 24 hours, accompanied where possible by withdrawal of the precipitating stimulus such as drugs such as causing syndrome of inappropriate ADH. Oral urea in chronic cases of syndrome of inappropriate ADH secretion, the 30 to 50 gram of urea is given oral. Oral vasopressin receptor antagonists such as tolvaptan may also be used to block the vasopressin mediated component of the water retention in a range of hyponatremia condition, but in those conditions there will be acute water retention and that will cause very edema. So we have also discussed the condition that is called diabetes insipidus, which also causes hypernatremia. Diabetes insipidus is due to central and nephrogenic central diabetes insipidus, the deficiency of ADH, and central and the nephrogenic diabetes is due to the non-responsiveness of the receptors, nephrogenic ADH receptors in the kidney to the ADH. So this was about. If we take another case of severe asthma and with severe asthma and he develops alkalosis, respiratory alkalosis, tingling, numbness. In those cases, his ABGs would show raised pH and low bicarbohydrate, carbon dioxide and bicarbonates will be normal. So once again we go to the topic of we are given this time shorter topics. So we once again discuss the respiratory acidosis. In this case, the condition, the hydrogen ions are greater than 40 millimole. In metabolic acidosis, the hydrogen are again greater than 40 millimole, nanomole liter, but in this case, bicarbonates are low. In this case, and carbon dioxide is also low. In case of respiratory acidosis, PCO2 is high and the bicarbonates are also high. So respiratory acidosis has two types, which is called acute and chronic. In both conditions, there is raised bicarbonate levels. The causes of acute type of acute respiratory acidosis or acute type 2 respiratory failure. Those are the conditions with acute severe asthma, acute exacerbation of COPD, and upper respiratory obstruction, acute neuropathies and paralysis, narcotic drugs, primary alveolar hypoventilation, flail chest, injuries, and chronic respiratory acidosis in which the carbonate levels will be very high. That is characterized by COPD. The causative factors are COPD, sleep apnea, kyphoscoliosis, myopathies, muscular dystrophies, and ankylosing spondylitis. Symptoms of respiratory acidosis include acute respiratory acidosis, headache, anxiety, blood-vision, restlessness, confusion without treatment. Other symptoms are sleepiness or fatigue, lethargy, delirium, confusion, coma. Respiratory acidosis is characterized by memory loss, sleep disturbance, personality changes. A patient is having acute respiratory paralysis due to the Guillain-Barré syndrome. In that cases, there will be a PCO2, the pH will be low, PCO2 will be high, and bicarbonates will be increased. In cases of narcotics-induced respiratory depression, respiratory suppression, there will be reduced heart rate, there will be history of drug intake, respiratory blood pH will be low due to the high hydrogen levels in the blood. PCO2 will be high and bicarbonates will be greater than 24 millimole. And in certain cases, there is compensatory response in which the bicarbonates can. So, this was the second case. Now we go to the condition which is called respiratory alkalosis. In respiratory alkalosis and metabolic alkalosis, what are the differences? Metabolic alkalosis, in which the hydrogen ions are less than 40 nanomole per liter, bicarbonates are greater than 24 millimole, and PCO2 is greater than 5.33 kilopascals. In respiratory alkalosis, the pH is less than 40 nanomole per liter. PCO2 is less than 5.33. In case of respiratory alkalosis, the PCO2 is low. In case of metabolic alkalosis, the PCO2 is high. In case of metabolic alkalosis, the bicarbonates are high. In respiratory alkalosis, bicarbonates are high. The causes of respiratory alkalosis are as a result of respiratory center stimulation, which includes CNS disorders, tumors, coma, strokes, and infections, hepatic failure, sepsis, pregnancy, anxiety, panic disorders, pain, drugs like aspirin, progesterone, theophylline, catecholamines, psychotropics. Patient who is on psychotropics may hyperventilate as well and can have respiratory hypnosis. Hypoxia, if the patient is have pneumonia, pulmonary edema, pulmonary embolism, pneumothorax, aspiration will cause hypoxemia and hypercarbia. Now, cardiopulmonary diseases, pneumonia, pulmonary edema, emphysema, pulmonary fibrosis, pneumothorax, pleural chest, pulmonary embolism, high altitude, congestive heart failure, pulmonary hypertension, pulmonary stenosis, mitral valve disease. Number D, mechanical hyperventilation. When someone is on ventilator, he can develop on ventilator, he can develop hyperventilation. Signs and symptoms of respiratory alkalosis depends upon the cause, neurological, lightheadedness, numbness, and tingling, confusion, inability to concentrate, blurred vision, cardiovascular dysrhythmias, palpitation, rapid breathing, miscellaneous dry mouth, technic spasm, arms and drugs. Respiratory process is usually of short duration approval anxiety state as a result of over as a result of over vigorous assisted ventilation. It can be prolonged in the context of pregnancy, pulmonary embolism, chronic liver disease, and ingestion of certain drugs such as salicylates, aspirin, and directly stimulate the respiratory center in the brain. Clinical features are those of underlying cause, but agitation associated with perioral and digital tingling may also occur, as alkalosis promotes the binding of calcium to albumin, resulting in a reduction in ionized calcium concentration. In severe cases, Clausius sign, carpopedal spasm on pressing the arms and thoracic signs, stroking the facial nerve causes facial spasm may be positive, and tetany and seizures may develop. Management involves correction of the identifiable causes and reduction of anxiety and period of rebreathing into a closed bag to allow CO2 level to rise. A young patient comes after a ingestion of tablet aspirin large doses. He develops hyperventilation and he has his ABGs were carried out, which shows uh, respiratory alkalosis. So, what will be the features of respiratory? That is mean that his bicarbonates level will be high, bicarbonate levels will be low, and his PCO2 will be also low. So, in case of respiratory alkalosis, these will be. So in the same way, if someone is having a patient having having acute having chronic sleep apnea syndrome for a long duration of time develops severe bacterial develop pneumonia. He has a pH of 7 point pH of 7.3 7.25, and his bicarbonates are greater than 5.33, and his bicarbonates are greater than 24 milliliters. What is the likely diagnosis? Is respiratory acidosis. Patient in case of respiratory acidosis, acute respiratory acidosis. If a patient with panic disorders comes with hyperventilation state, we carry out his ABGs, which shows pH of greater than 7.5 and PCO2 is less than 5.33 kilopascal and bicarbonate is less than 24 millimole per liter. What is the diagnosis? Diagnosis is respiratory alkalosis. The patient with myopathy develops pneumonia and his ABGs are his pH is less than 7.28 and his PCO2 is greater than 7.7 or his PCO2 is greater than 5.33 kilopascal and bicarbonates are greater than 24 millimole, that is 29 millimole. What is the diagnosis? The diagnosis is respiratory acidosis. A patient with road traffic accidents develops flail chest injury, and his ABGs show that his respiratory rate is 25. His ABGs show the pH of 7.3 and his PCO2 is greater than 5.33 kilopascals and his bicarbonate level is greater than 28. What is the likely diagnosis? The likely diagnosis is respiratory. Next we patient with poor dosage of theophylline has developed cardia. He is also hyperventilating, asthmatic, and his ABGs are done, which shows the pH of less of 7.55, hydrogen ions are less than 40, and PCO2 is less than 5.33 kilopascals. That is, and his bicarbonate are less than 4 millimole per liter. What is the diagnosis? Diagnosis is theophylline toxicity. चलो जी बंद कर ली स्टॉप शेयर इससे बात हो सकती है ये हैं बेटे इनसे तुम्हारा क्या कहना चाहते हैं हेलो हेलो हैं लीव मीटिंग